Thank you so much. I want to thank Seychelles for the opportunity, and I want to thank the panel for inviting me and delay me so I can have more people presenting today. First slide. There. Okay, these are my disclosures. I'm doing the FDA trial for Baranova. I am the PI, and we have a grant for this trial. And those are my other disclosures with other companies I discussed earlier, Valentics. We know that obesity is prevalent in the US. It doesn't matter if you're a man or a woman, you have equally percent of weight. 33% of people are obese. So the future, if you're a bariatric surgeon, is very good. This is a disease that is not going away. We know that today there are many conditions that can be cleaned with weight loss. And I think that this is important when we talk to our primary care physicians about why endoscopic approaches may do have an impact in the patient's comorbidities. We know also that 5 to 10% of excess weight loss is all is needed for decreasing mortality in around 25%, decrease in type 2 diabetes in between 30 to 60%, and we obtain with that weight loss a significant reduction in the metabolic and the cardiovascular risks. And this is part of what I was talking earlier, where we should not be comparing endoscopic approaches with surgical approaches. They are two different things. And we are attracting patients that do not want surgery. I think that it's naive for us as surgeons to believe that every patient wants an operation. If we look at the growth of bariatric surgery, it has not been very good. It should be at 400,000 patients a year now, and we are at 175. So clearly, the patients want surgery, but not every patient that needs an operation or needs to lose weight wants an operation. And that's where the medical non-invasive approaches do have a future. And the same is true for gastroesophageal reflux disease. And this is what I'm talking about. If we look at 800,000 patients that may qualify for surgery in the US, that's 1%. We are only touching the tip of the iceberg. Can I have my pointer, please? I lost it. If you look at, no, one back. Okay, the pointer is not working. If we look at 2.5% of those patients are doing lifestyle changes, 1% are having surgery, and the 1% is on medications, it's pretty depressing. And I'm saying this seriously. We should be doing more. This is kind of rubbing the tip of the iceberg. And this is where I am a believer in endoscopic approaches. What I'm going to discuss today is one of the many that we are doing at UC San Diego. We are involved in probably every type of the procedure. This is called the Pyloric shuttle system. And what you see there, I don't have the mouse. Guys, can I have the mouse? It's not moving. It was moving earlier. It has a bigger area. These are the dimensions. The bigger face is around 5 centimeters in diameter. The length of the device is around 20 centimeters, with a lower end that is around 2 centimeters in length. And what you have is an inside coil that we will place during the endoscopic delivery. I will show you that in a minute. So this will go transorally. You will inflate the bigger part with the coil, and you will have the shuttle there. Okay, nothing is working. Okay. So you have two components. One is the delivery device that you place through the mouse, and through that you place the shuttle. The shuttle goes in, and then you have the access sheaths that allow you to deploy the coil. And then you have the removal components, and those are devices that are used to really pull the coil out and remove the shuttle important to see is that you don't use saline. So the weight of the device is very minimal compared to other devices, and we will see that later. And this is what you see on X-rays. The one on your right, unfortunately, the mouse is not moving. Now it's moving. Now it's not moving. Now it's moving. Can you go back? This is why I like to have my computer up here. Can we go back, please? Back. Previous slide. So you have here on the right side, on the left side, the shuttle not deployed. You see the stomach, but it has not gone into the duodenum. And what you see on the right side is the big ball in the stomach and the tiny one inside the duodenum. So really tamponating the pylorus, working as a shuttle. And this is how it's placed. Now okay, now it's working. Awesome. You can remove the noise. So we're going to go in endoscopic. This is the coil that I was talking to you earlier. It's placed inside, and so we don't use saline to inflate the shuttle, and that's probably where you will see the data is the reason why the patients are not having so much nausea. So Tom was saying that they do it in 40 minutes. I'm going to show you how we place this at UC Santiago in 3. You see how fast we are? So you place the overtube, then you place your shuttle inside, you deploy the coil, as I'm doing right now, and then the shuttle will stay there, and later it will migrate into the duodenum, and will move in and out as needed to allow for emptying of the stomach. And then at 6 months, you will go in, remove the plug over the scope, take the coil out that you placed before. So use that with an overtube so you don't damage the GE junction. So all your pulling is through the overtube. The coil comes out again one more time, and then the shuttle is removed through the lower end. It looks very easy. It's a little more complex in the operating room, but it's pretty straightforward. So you grab that with a snare and you pull back. So as we have said always at SAGE, bottom line of today's presentation is if you don't do endoscopies, you're dead. So as a surgeon, you need to do endoscopies. We cannot have GI been doing these things in the operating room. So this was the feasibility study done outside of the US, 20 patients. Group 1 was patients that had the device for 3 months. Group 2, 6 months. And the patients had a BMI between 30 and 50. The deployment was successful in all the patients, so they have very good success there. No safety issues. And there were not extended hospital stay. The average deployment time was around 10 minutes. The procedure in total 45, and the retrieval time was around 12 minutes. We do put times. I don't think that time matters that much anymore. As I'm getting older, I am against time. I'm more about quality and outcomes more than time. But industry likes to put time in the studies. And we look at the patients, there were similar groups. There were older patients on the 6 months group, and they were a little bit sicker. They have more sleep apnea, more osteoarthritis, and one patient with diabetes. And the excess weight loss was pretty good. As expected, the patients that had the device for 3 months achieved a 30% excess weight loss, but as the device stayed longer time, the weight loss was 50%. And without any bias, this is almost twice the weight loss achieved by the other balloons. So if we can duplicate that with the FDA trial, I think that there's an opportunity here. And this is a excess weight loss, percent of excess weight loss around 58% at 6 months. Interestingly, as we would have expected more nausea, nausea was not one of the biggest complaints of this patient. Sore throat was. We learned with Pablo Melanchthuk in Mendoza that one of the ways to avoid sore throat is we place silocaine cream around the overtube, and the sore throat really goes away. So I will advise that if you're placing stents or overtubes, use silocaine cream around the overtube. Nausea was only found in 2 patients. That's pretty low. Reasons for that, I'm not sure, but very likely the weight of the balloon may have done that. And what is important to point out that 10% of those patients have ulcers in this initial feasibility trial, and that's 50% of patients with ulcers is a big number. None of them needed reoperations, none of them perforated, but they were decubitus ulcers due to the balloon. And that was addressed by the company. The balloon, the Gen 2 balloon we are using for the FDA trial here in the US, is the one at the bottom, has smoothed edges. Hopefully that will limit the amount of ulcers we see. So there was a redesign of the device, and the company feels comfortable that this will improve the outcome. So the US trial is starting now. I think that we already have some patients placed. I'm not allowed to disclose them. BMI is 35 to 50 to 40 are the patients that we're trying to achieve, or more than between 30 and 35 with comorbidities. This will be a randomized sham-controlled double-blind trial. Primary endpoint will be total body weight loss, treatment of the control group, and secondary endpoint will be BMI change, quality of life, comorbidities, and satiety. So we are planning to enroll them. We want patients with type 2 diabetes and hypertension. With type 2 diabetes, they need to meet the criteria of having hemoglobin A1C between 6.5 and 7.5, and they should be controlled. And this will be our endoscopic exclusion criteria: strictures, Barrett's, erosive esophagitis, gastric masses, and peptic ulcerations. I am sure that esophagitis and Barrett's will not be contraindication in the future, since this device is only played for 6 months, but for this particular trial, they are. This is difficult to read. I don't like to put these slides, but patients will undergo an endoscopy at the time of the device placement, and at that time they will be included or excluded. And if they are included, then the randomized trial will happen at that time with the endoscope in the patient's mouth. So it will not happen before the endoscopy is done. And these are the FDA trials. It's a good, solid group of surgeons, Aurora Pryor and Rothstein in Dartmouth, a group in Dallas, us, Revis in Portland, Swain in Scottsdale. And I think that next year we will have much good data, and probably we'll have US data we're able to present here. Thank you very much.